Hi, I'm Dr. Jack Cush. This is the RheumNow Week in Review. It's the 9th of December 2016, and these are the highlights from this week on the website rheumnow.com. There's an interesting report about what we should be doing with regard to our rheumatoid arthritis patients and their cardiovascular risk. An analysis of the data has shown what really has been shown before, which is that RA patients we know have an increased risk of cardiovascular events and death. This particular analysis compared that risk to that seen in patients with diabetes, where there's, for both conditions, a twofold or higher risk of cardiovascular events. And the authors challenge rheumatologists to maybe take a more primary role in managing cardiovascular risk. One, by obviously treating rheumatoid arthritis aggressively, but two, also by maybe doing cardiovascular risk assessments, by initiating therapy, by being the person who drives the risk discussions with the patient and continues that on with primary care. Many rheumatologists are certainly aware of the comorbidities associated with rheumatoid arthritis and discuss them with their patients, but many of us also assume that comorbidity management is going to be done by someone else. And that would be true in an ideal world. However, most of our patients actually don't see primary care doctors and think their rheumatologist does it all. So an interesting report that challenges maybe the way we do business. Another citation that we tweeted this week was about smoking. And it was shown in large population-based studies that smoking doesn't necessarily increase autoantibody formation in non-rheumatoid populations, so-called normal populations. The incidence of autoantibodies being found in that setting is quite low. However, in a rheumatoid arthritis population, when you look at the influence of smoking, what they found was that it not only induces rheumatoid factor, CCP, but it often induces multiple autoantibodies, suggesting that there may be a loss of tolerance with smoking, and it sort of feeds the belief that we are primed by our genetics and modified by our environment to develop autoimmune findings that may antedate the onset of disease. Two interesting cases I had this week I tweeted about. One was tumor-induced osteomalacia, a patient who has multiple fractures and pain was found to actually have tumor-induced osteomalacia. Such patients have phosphatate loss in the urine. They have very low phosphate levels, very high alkaline phosphatase levels. And this particular patient, who I thought was manifesting unexplained and new fibromyalgic findings, was in fact probably having findings related to their osteomalacia with fatigue, arthralgias, and myalgias. The problem is that these are induced by very, very small tumors that are very, very hard to find. Usually can be found in either the appendicular or axial skeleton, sometimes in the facial bones, but it's due to a high levels of a fibroblast growth factor 23 mesenchymal tumor that induces the bone disease and the osteomalacia. This particular patient, we're still looking to find the source, but again, the patients who have multiple fractures, otherwise unexplained, look at the phosphate levels. That might be the clue. Another patient I had this week, actually, with recurrent ulcers and periodic fevers, may be thought to be due to Behçet's or an autoinflammatory condition, but in fact, she probably has adult onset FAPA syndrome. That's PFAPA, standing for periodic fever, aphthous ulceration, pharyngitis, and cervical adenitis. That is the syndrome. Very common cause of monthly periodic fevers in children, with the associated lymphadenitis, sore throats, and fevers. Such patients may have arthralgias, myalgias, GI complaints. But what's interesting about this, that this autoinflammatory, non-Mendelian autoinflammatory syndrome can also be described in adults, and the citation we give you is 30 patients with a mean age of onset of 39. So again, the patients don't generally have very high fevers. They tend to be, in the fever world, kind of on the low range, 100 to 102. They can be higher, but It's not as high as you get, for instance, with Still's disease, but nonetheless, they get sort of monthly, every 4-week regular fevers. Responds really, really well to a single dose of high-dose prednisone, like 60 milligrams a day. Another common treatment, at least in the pediatric world, is to do tonsillectomy, which should make up to 70% of patients better. So consider the FAPA syndrome, also known as the Marshall syndrome, in adults who have periodic fevers and oral ulcerations. There's a nice analysis looking at the genes and SNPs that we know are associated with rheumatoid arthritis risk and onset, the so-called HLA-DR beta-1 alleles that are associated with the disease. And a big analysis looked at those genes and what that may mean as far as ultimate outcomes, arthritis outcomes, and drug responses. It shows that those genes really have very little influence in a large population-based study. A study of over 300, in fact 323 patients with ANCA-associated vasculitis showed that 33 of them developed a total of 45 malignancies, suggesting that 10% of patients with ANCA-positive or ANCA-associated vasculitis may develop a malignancy. It turns out that if patients were treated with Cytoxan, they tend to have a 3-fold higher risk of malignancy than would the general population. But if they were treated with rituximab, the risk is not any different than the general population, maybe as much as 33% lower. That's a non-significant lowering, but nonetheless a lower number. Comparatively, if a patient was treated with Cytoxan versus rituximab, there might in fact be a 4.6-fold higher risk of malignancy. So might tell us something again about how we should be treating ANCA-associated vasculitis in the future. A BMJ study looked at over 19,000 men who were taking regular testosterone and showed that this was associated with up to a 63% increased risk of venous thromboembolic events, especially and really only in the first 6 months. Thereafter, the rate went down and was not any different than the comparative population. I came across an interesting syndrome this week called the Tafro syndrome. The name itself reminds me a little bit of the Sappho syndrome. Tafro, I'm not sure what the acronym stands for, but it is a syndrome that is in the family of Castleman's disease and tends to be an IL-6 driven process. Hence, patients may respond to IL-6 inhibition. It is an inflammatory disease where patients present with thrombocytopenia, pleural effusions, anasarca, edema, fever, renal insufficiency, organomegaly, hepatosplenomegaly, lymphadenopathy. Again, in that same, no diagnostic test, it is a syndrome, but nonetheless a pretty rare report when one finds it. And lastly, a nice review from what's a registry of patients with catastrophic antiphospholipid syndrome. A registry of 500 patients showed that 33% of these patients actually had a diagnosis of lupus, so that's surprising. I would expect maybe more, but that death was seen in 37%. Manifestations include renal 73%, lung 60%, and half of them had either brain involvement, heart involvement, or skin involvement. A nice review of catastrophic antiphospholipid syndrome. The INTRACT study was also in the literature recently. This is a study that actually compared the outcomes of rheumatoid arthritis patients who are seropositive, and they either put them on etanercept or on tocilizumab. The idea being that might these affect cardiovascular outcomes when given to patients with high-risk disease, high CRPs, very active RA, over the age of 50, with at least one cardiovascular risk factor. A 3-year trial that actually started somewhere around 2011 was only recently completed. Again, 3,080 patients. When it looked at the primary outcomes, which were MACE, major adverse cardiac events, they were not different between the etanercept group and the tocilizumab group, 78 and 83. Cardiovascular deaths were similar, 35 and 36, and non-fatal MI also similar, 28 and 31. Again, there was a small increase in LDL in about 10% of patients on tocilizumab, more so than the etanercept group. And the adverse events were not significantly different, but there were numerically more in the tocilizumab group, suggesting mainly for SIE, GI perforations. So while there was no difference in the cardioprotective effect of cytokine inhibition, whether it was TNF or IL-6 with these biologics, that was good news. The The trade-off is there a difference in the safety profile in the long run for your individual patient? That's for you to decide after you look at the data. The next report that we had was the Exhilarate study. An Exhilarate study was published last week in Lancet. Actually, it was on, I think, online during the week of the ACR. And the Exhilarate study is a head-to-head trial of two TNF inhibitors, adalimumab and certolizumab, and it's a very notable trial because the primary endpoint of this trial was ACR20 response at week 16, and the study was powered for certolizumab to actually beat adalimumab. In fact, it was powered such that they expected that certolizumab would do 62% ACR20 at week 16, and the other TNF inhibitor would do 50%. And it turns out that the outcomes in this trial were exactly equal at the primary endpoint of 16 weeks and for ACR20, and at the number of patients in remission at week 102. So again, when you compare this, again, the overall responses were for ACR20 were 69% versus 71%. And again, these patients were on background methotrexate of varying disease duration, but they had very active disease. And then DAS, not remission, but low disease activity state was 35 and 33% at week 104. The interesting thing about the study is that it is a head-to-head. It failed to be a superiority study. It was, in fact, showed that it was equal. The other interesting thing about this study, I guess, it was that it was done in methotrexate patients, but it was open label, meaning that everyone was guaranteed to get therapy. So in the end, when you look at the curves, it looked like patients were achieving 80% ACR20 response rates. But if you did not achieve a low disease activity state by week 12, you were exited and flipped over to the other arm. And what that showed was, and so those would be primary non-responders. And what that showed was that if you didn't respond and you were given the other drug, your chance of a response to the second TNF was only 40%. That's an important thing because we tend to expect when we switch TNF inhibitors to have a 50% or greater outcome. My take home from this study is the following. Number one, all TNF inhibitors are basically equal. Why you'd want to show that yours is better than theirs, I don't know. To me, they're all about the same. There are differences in them, but don't expect them to be major as far as efficacy. Number two, head-to-head trials are costly and time-consuming. And I've yet to see a head-to-head trial that's actually changed the practice of rheumatology sufficiently. I wouldn't invest in them. The primary non-response to a TNF inhibitor really should be an invitation to change your mechanism and switch to another biologic, a non-TNF inhibitor biologic. There's enough evidence out there that that is the better choice in those patients. Now, if your patient is a failure for other reasons, not a primary non-response, a secondary non-response, or developmental toxicity, another TNF inhibitor seems to make sense to me. This study also underscored the fact you only need 12 weeks to make up your mind about whether a patient's going to respond or not. To say, well, I'm going to wait another 12 weeks is really just to wait for a few more stragglers to come in to give you low-level responses, which are not meaningful. You're looking for a meaningful big-time response. Make that decision, I think, in 6 weeks, but this study says 12 weeks is fine. And again, this study actually had higher than the usual 60-40-20 response, but that's because there was background methotrexate, and there was also an expectation that you were going to get a real biologic in this study. So I think that's significant, and I think that's one of the reasons why you won't be seeing a lot of head-to-head, at least superiority trials going forward. Lastly, we had a report in the literature about the literature showing the next new JAK inhibitor that's being developed. Well, the first one is, we know, tofacitinib. The next one is baricitinib, which is in development, probably approved early in 2017. And the next one after that is ABT494. This is a JAK inhibitor coming from AbbVie, and there were two reports in arthritis and rheumatism, also known as arthritis and rheumatology. Why they changed, I don't know. But these drugs were given and reported to two large cohorts, a 300-patient cohort and a 276-patient cohort, reported by first Mark Genovese and the other by Joel Kremer, showing really impressive ACR20 response rates, no new safety signals. Again, this is going to be the next JAK inhibitor. We await more trials going forward. So that's it for this week at RheumNow weekly report. You can go to the website and get these citations and look up the information if you want more. Tune in to RheumNow for more news and information. Have a great weekend. We'll talk to you next week.